Okay, it's time to start. It's 8:31. This is the session, Intracoronary Imaging New Insights. I'm Gary Mintz. My co-moderator is Myeong-Ki, and who'll also give the first talk. Shh. Long journey of imaging-guided PCI, why we need it.
Thank you, Dr. Mintz. I'm going to talking about the long journey of imaging-guided PCI, why needed. My disclosure. As we know, the coronary angiogram is a luminogram. Compared to the coronary angiogram, the intravascular imaging allows a real-time tomographic assessment of the lumen area, plaque composition, vessel size, and the distribution. Therefore, use of intravascular imaging during a PCI absolutely translate the improved clinical outcome. However, in the era of the bare metal stent and the fourth generation DS era, the demonstration of a clinical usefulness of the IVUS was not performed. In the bare metal era, the time is late 1990 and the early 2000. The random study, for example, a REGIST or Opticus trial, failed to demonstrate the clinical usefulness of the IVUS in the PCI procedure. Main reason is total sample size is small. REGIST is 154 and the Opticus is 457. And the region is total stent length is quite shorter. It means a small sample size and the simple region is failed to demonstrate the clinical usefulness in the bare metal era. What about the first generation era? In the home DS IVUS study, in this study, total sample size only 210, and the mean stent length is only 23. Therefore, this study also demonstrates the clinical usefulness of the IVUS in the fourth generation DS. In a simple lesion, DS stent length less than 24 in our random study in the LISET trial demonstrate that there is no difference of the clinical outcome between the angio-guided versus the IVUS-guided demonstration. However, in the first generation DS, when the stent length less than 40, the angiographic restenosis is only 1%. However, the stent length is more than 40, is that the angiographic restenosis rate was 13%. It means that the stent length is longer. It means that the complex lesion is different. Therefore, at that time, in 2011 and 2014, the American and the European guideline recommend the IVUS only left main stenting or the stent optimization. Indication is a class 2A, 2B, and the level of evidence is only B. So low level of the recommendation to use IVUS. However, 2015, in the current generation of the DS era, the IVUS XPR study and the CTO IVUS study was demonstrate the clinical usefulness of the IVUS in the PCI procedure. The success is mainly the number of study population was increased in the 1,400 and in the more complex lesion like a long lesion or CTO lesion subset. This is the first meta-analysis at the time in the exclusively randomized clinical trial to compare the IVUS and versus the angio-guided implantation. The result is better in the IVUS compared to the angio-guided PCI. Actually, this first meta-analysis driven by the patient-level data. However, the previous IVUS XPL and the CTO trial was the main reduction, main improved clinical outcome was driven by the TRL, soft endpoint. However, use of the IVUS during the procedure may translate the hard endpoint. Therefore, we combine the LISET long and the CTO and the IVUS and the IVUS XPR study. This is the patient-level data. And we define the hard endpoint, excluding the TRL, only cardiac death, MI, or stent thrombosis. This data clearly show that the IBS-guided intervention is an improved clinical outcome compared to the angio-guidance in respect of the hard endpoint. Then in 2018, the ultimate trial was reported, and in this study population is an all-comer patient. And then at the time the American and the European guideline 2021 and 2018, the IBS was recommended in the left main or complex lesion or stent optimization. The indication is still class 2A. Level of evidence is a B. Still a little forward is not sufficient, even though there is the publication of the randomized data or the meta-analysis. Last year, as we know, a very important study was reported in the New England Journal of Medicine, Renovate Complex PCI and October trial. It's a positive data in the complex lesion. We have to use the imaging study. And this year, another important study on the IBS ACS study also reported a better clinical outcome in the IBS-guided PCI compared to the angio-guided PCI. What about the long-term benefit? From the data U.S. Medicare source or Korean single center experience, a report that the clinical benefit of intravascular imaging was maintained up to the 10 years. This experience, the benefit of clinical benefit was more predominant in the less experienced operator compared to the experienced operator. Therefore, intravascular imaging is more useful in the young interventionist. The cost effectiveness also prominent in the 99% of the patient who undergoing a PCI. The use of the IBS is the most cost effectiveness. Ladies and gentlemen, therefore, I'd like to conclude that I would like to claim as follows. IBS or the OCT should be considered in patient from a complex PCI classification from the 2A to the 1A, and the level of evidence from B to A. Thank you for your attention. Thank you.
Thank you. We will move on to the second presentation by Evelyn Regar, Time to Adopt Intracoronary Imaging in Your Cath Lab, How to Start a Program.
Good morning, everybody. So how to start a program? I put a couple of points together for you, which some might be obvious, some not so much. So first thing is manage resources and expectation. Especially if you are a young doctor and you are put in charge of building an intracoronary program, make sure that you clarify which resources are available to you. Manpower, which image technology, how many catheters, is the cath lab okay? Do you need adaptation construction work in the cath lab? What is the budget and resources for training? Logistics for analysis, documentation, and storage of the imaging data, and also clarify upfront the expectations. How is your success defined, and what are you expected to accomplish within a year? Second thing that you should start to think about upfront is how to build a structure for regular knowledge transfer. Plan regular team meetings and assure protected time for attendance. And this is not a no-brainer in a cath lab where the treatment of patients might depend on the presence of your cath lab nurses or technicians that you picked for your team. Regular meetings is important for training purposes, case reviews, and analysis to bring the team forward. Then select your team, and I would strongly advise to select an interdisciplinary core team for intracoronary imaging with cath lab nurses, technicians, cardiologists in trainings and fellows, and interventional cardiologists. Why? You should not do it on your own, because your goal should be to have a 24/7 intracoronary imaging service available in your cath lab. Once you have your team, it's the task to train the team. This is not only about handling of consolence catheters, it's also about preparation in the cath lab, preparation of the patient, clarify who is doing what before and during the imaging procedure, and establish a workflow in the cath lab to perform successful imaging. I cannot put enough emphasis on the team aspect of successful intracoronary imaging. As a leader of this team, you must be sure that you enable and endorse your team to make sure to share the responsibility for an optimal imaging procedure, to value the extra effort your team members are investing, and respect their input. When starting a new program, everybody is a beginner, everybody is a learner, and everybody has to contribute to the pool of experience. We are not there yet. The next task is to make sure that you reserve extra cath lab time, because in the beginning, intracoronary imaging cases will require more time than routine angiography cases. Why is that? First, there is a learning curve, and whatever you do, you have to deal with the learning curve. People have to deal with new machinery, with new workflows. You, as an operator, will need time to image interpretation. You will need time to change your mind and change your PCI strategy, and you might, especially in the beginning, require multiple imaging runs in order to understand what you did and where there is still room for optimization. Only with enough time you can assure a relaxed, safe learning environment and a safe treatment environment for the patient. Then there is the next task for you. How to bring intracoronary imaging into practice. And here the key word is standardization. Establish a regular imaging schedule, like having imaging days, like 4 days a week or once a day, but plan it and make it clear to the team. When you perform imaging, do it always in a consistent, standardized way. For example, always give IC nitrates up front, always film the distal position of the imaging catheter in the vessel, always use a motorized pullback, always use the standardized speed, always use standardized display settings of the image, for instance, the magnification factor, and always the same way of flash administration, flash medium and flow rate if you do OCT. Moreover, perform imaging in a consistent, standardized order. So people need to know that you always do a pre-intervention intracoronary imaging and always insist on a final imaging run at the end of the procedure, because this is the run where you will learn and reassure the success of your procedure. And by doing so, you are giving your team the opportunity to prepare and to anticipate what you are expecting from them. Still not done. In the cath lab, be prepared to allow for errors, because in the beginning, you will have imaging runs that are not of optimal quality. You will have measurements performed on the wrong section in the vessel. You will maybe face things like, oops, the imaging has not been recorded, or you will have catheters that break during preparation. So stay relaxed, take the time needed to recognize and to correct the errors, and trust. There will be a steep learning curve, and these errors will be overcome quickly. Trust is another important word, and this is for you as an operator extremely important. Trust the intracoronary imaging findings and dare to act accordingly. If you not trust the imaging, if you don't dare to act, whoever should do this, whoever should believe the program. So take your time to review carefully the imaging run. I often ask a team member to interpret the imaging run for me. First, it keeps them busy and engaged. These are fresh ideas, and I buy myself time to digest what I've seen. Don't hesitate to review again and again multiple times, even in the spot in the Cath lab. And then explain your conclusions and your decisions on the treatment strategy to the team around you. Once you have done all this, don't forget to document the intracoronary imaging findings and your therapeutic decisions. Find a way to document it in a standardized way in the patient file. Create a form to have standardized and transparent reporting. Record your changed in PCI strategy based on the IC imaging. And don't forget to record imaging-related complications. The latter two things are not so obvious in the beginning, but they will help you to stabilize and justify your program over time. Also ensure the availability of the image runs for later review, other than just on the imaging console. So the most important point, review all intracoronary imaging cases with your team. Re-evaluate the image interpretation, re-evaluate the treatment decision and strategy, identify sources of error, and generate ideas for improvements. Be part of the team and enable your team members to become experts. Invest in an intracoronary imaging team, because the better your team, the better your procedures, and the better the prognosis of the patient. Thank you.
That was great and very practical. So our third talk by Sri Bangalore, imaging versus functional versus angio-guided PCI, state of the art.
Thank you very much, and thanks for inviting me. So this is a great session. So I'll try to kind of summarize everything as it stands as of today in terms of imaging and functional guiding versus angiographic guided PCI. So these are some of my disclosures as it relates to this particular talk. Let's first start with what we know of functional guided PCI. So I must say the clinical outcomes, if you look at functional guided PCI, has been variable. What do I mean by that? I mean, if you look at the FAME trial in 2009, 1,000 patients with multivessel disease, a third of them with unstable angina, patients were randomized to FFR-guided PCI or angiographic-guided PCI. And FFR-guided PCI is significantly reduced MACE when compared to angiographic-guided PCI. And this difference was also driven by a difference in death or MI, so significant lower death or MI with the FFR-guided PCI. And there was also numerically lower MI in the FFR-guided group. But now, if you fast forward to 2021, Flower MI trial, just close to 1,200 patients with STEMI and multivessel disease, patients randomized to FFR-guided PCI or angiographic-guided PCI, there was actually no significant difference between FFR-guided PCI and angiographic-guided PCI. In fact, if you look at the MI rates, there was numerically higher rates of MI in the FFR-guided PCI when compared to angiographic-guided PCI. So clearly, what is the difference between these two trials? One of the major difference may be the enrolled patient population. So FAME is basically a stable coronary disease patients, whereas Flower MI is an ACS cohort. That leads us to the hypothesis that in ACS patients, perhaps plaque characterization is more important than a functional significance. What about intravascular imaging? Again, the clinical outcomes of intravascular imaging-guided PCI is variable, but I think it's less variable than what we saw with the functional guidance. You heard about the Renovate complex PCI, 1,600 patients complex CAD, randomized to angiographic-guided PCI or imaging-guided PCI. And clearly, imaging-guided PCI, 36% reduction in the risk of MACE when compared to angiographic-guided PCI, including a reduction in CV death and target lesion revascularization. However, ILUMIEN 4, 2,400 patients diabetes or complex CAD, randomized to OCT-guided PCI, angiographic-guided PCI. Primary endpoint was not statistically significant. In fact, there was no difference in TLR between OCT-guided and angiographic-guided PCI. There was a reduction in stent thrombosis with OCT-guided PCI compared to angiographic-guided PCI. So let's look at guidelines, and I think it's important to frame this in the context of diagnosis and post-PCI optimization. So this is 2021 ACCHA REVAS guidelines. In terms of diagnosis for intravascular imaging, it's a class 2A for intermediate stenosis of the left main, or in case of stent failure, imaging should be used. In terms of post-PCI optimization, it's a class 2A to consider intravascular imaging for left main or complex coronary stenting. You know, I had the privilege of being part of the guidelines, and many of us did debate at that time that it should be a class 1, but there were many large ongoing randomized trials which made us take a step back and give it a class 2A indication. Moving forward, if you think of functional guidance, for the guidelines, we say for diagnosis, it's a class 1 to use functional guidance in patients with intermediate stenosis, and you can use either FFR or some of the resting indices. But in terms of post-PCI optimization, we stayed silent on not having any recommendation for post-PCI functional guided optimization of PCI procedures. So we looked at some of the data from randomized trials, looking at intravascular imaging guidance, whether it's IVUS or OCT, or functionally guided PCI when compared to angiographic guided PCI. We looked at clinical outcomes, if there is a difference in clinical outcomes between the three strategies. And we also wanted to test the hypothesis whether the results would change based on ACS versus non-ACS trials. The primary outcome was MACE, as was defined in each of these trials. Typically was a composite of CV death, MI, and TLR. And we looked at a host of secondary endpoints, including all-cause death, CV death, MI, stent thrombosis, and TLR. We had 32 randomized trials, 22,000 patients. 19 of those were ACS trials and 13 were non-ACS trials. Here you can kind of see the comparisons between angiographic, intravascular imaging, and functional guided PCI. If you look at the endpoint of MACE, we can see here that intravascular imaging guided PCI, there was a 28% reduction in MACE when compared to angiographic guided PCI. The results were somewhat similar for functionally guided PCI. And when we compared head-to-head intravascular imaging versus functionally guided PCI, no statistically significant difference, but the point estimate seems to favor intravascular imaging. We then ranked these treatment strategies, and in this rankogram, for the endpoint of MACE, intravascular imaging ranked number 1, and angiographic-guided PCI ranked worst. And now moving on to CV death, again, intravascular imaging-guided PCI, significant reduction in CV death when compared to angiographic-guided PCI. Somewhat similar trend for functional guided PCI, and in our rankogram, again, intravascular imaging guided PCI ranked the best, angiographic guided PCI ranked the worst. For MI, again, both intravascular imaging and functional guided PCI reduced MI rates when compared to angiographic guided PCI. And in for the ranking, both intravascular imaging and functional guided ranked similarly and were better than angiographic guided PCI for endpoint of MI. Finally, for stent thrombosis, intravascular imaging-guided PCI reduced stent thrombosis and again was ranked the best, and angiographic-guided PCI ranked the worst. For TLR, we saw something similar. Intravascular imaging guidance was ranked number 1, and interestingly enough here, functional guided PCI was ranked the worst in terms of the endpoint of TLR. So we then did a subgroup analysis looking at ACS versus non-ACS trials, and the hypothesis here, as I pointed out before, that in an ACS trial, perhaps intravascular imaging and plaque characterization may be more important than functional characterization of a lesion. This is the subset of ACS patients, and uniformly for all endpoints that we tested, intravascular imaging were ranked the best, and for most endpoint, angiographic guidance ranked the worst. Interesting to also note that in ACS trials, functional guided PCI ranked the worst for the endpoint of TLR. For non-ACS trial, again, we see a similar pattern. Here, intravascular imaging was ranked best for all of the outcomes, and angiographic guidance was ranked worst for all of the outcomes. Some of the limitations of, for analysis was functional guidance was mainly used for PCI lesion selection, whereas in most studies, imaging guidance was used to optimize stent implantation. And of course, there are a number of other meta-analyses. Here is Greg Stone and Ziad's meta-analysis published in Lancet, looking at 22 trials, 15,000 patients. But this was mainly comparing intravascular imaging guidance versus angiographic guidelines. And the story is very similar. You see a significant reduction in all endpoints with intravascular imaging, including a 25% reduction in all-cause death. And here, there was a comparison of OCT guidance versus IVUS guidance, and the outcomes were largely similar. So just to summarize the state of the imaging guidance versus functional guidance as we stand as of today, intravascular guided imaging PCI and functional guided PCI were both associated with superior outcomes compared with the angiographic guided PCI. And for all outcomes, intravascular imaging guided PCI was ranked the best. And this was true both for ACS and non-ACS cohorts. Alternatively, angiographic guided PCI was consistently ranked the worst for most of the outcomes. I think we will eagerly await the results of COMPLETE 2, which is randomizing patients after an ACS to physiology guided versus angiographic guided complete PCI. And these manuscripts have been published in JACC, and you can see that there is a good editorial. Thank you for your attention.
Okay, so we've got about 5 minutes for discussion. Anybody from the audience who wants to ask a question, there's a microphone here. Just introduce yourself, and I'll ask the panel if they... Please.
I'm Dr. John from India. I would like to know the panel's opinion on, there was a meta-analysis of the 5-year pooled data of defined flare and IFR sweetheart, which showed that IFR measurement was not good in terms of mortality. Any comments on that?
I can comment on that. I think that was, it was probably just a spurious finding. There's absolutely no mechanistic explanation for that result. The difference in that result was not in the patients who were deferred. It's actually the patients who received a stent. So you would expect if there was going to be a mortality difference between the IFR and the FFR, it would be in those patients who were deferred, but it was actually the opposite. And none of the other outcomes, like MI was exactly the same. There's no explanation for it. It's just this one single outcome that's not supported by anything else in those trials. So it's likely a spurious outcome.
Yeah. And can I ask one more question, please?
Sure.
It is regarding QFR. What is the status of QFR in current practice?
Go ahead, Yoshi.
So I think angio-based FFR, there was, I think, 6, 7 commercially available softwares. And I think the most evidence is from the QFR from the MEDIS. And I think in Favor 3 China, there was a significant improvement in the outcome using the QFR as guidance compared to the angio-based PCI. And I think there's a couple of ongoing trials, such as the Favor 3 Europe, Japan, and also I think Niels knows more about that. But also the Pioneer 4 trial is ongoing to really see the clinical impact of using the QFR routinely for the guidance of the PCI. And then there was also many other softwares, like Pi Medical has a VFFR, and also there's Cath software is available. I think for those softwares, also the ongoing trial is trying to demonstrate the clinical benefit of this QFR guidance, and we have to a little bit wait to see all the result of the to test the clinical benefit of these softwares.
Thank you very much.
Can I ask a question?
Let me take one quick comment, and then yes. Don't focus on one study. Look at the totality of the data. And that applies to everything that we do. Sorry, go ahead.
Yeah, so I just wanted to take advantage that we're here in South Korea and with our Korean and Japanese colleagues. In North America and Europe, we generally when we do a primary PCI, we do not image. We open the lesion to the, in most centers they don't image. We're finding in COMPLETE 2 where we're bringing patients back for 3-vessel imaging in patients with STEMI, and they're imaging the culprit vessel, that we probably don't do a very good job of stenting the culprit lesion in patients with STEMI. So I just want to comment on, is it your practice to routinely image the culprit lesion in patients with STEMI? And do we have any data or outcomes or trials looking at that?
Well, I can certainly answer the last question. You've got IVUS ACS, which was a 3,500 patient Chinese study. And they weren't just ACS patients, they were a solid quarter, 30%, were STEMI and non-STEMI, and the outcomes were better. So, is that definitive? No, but there's a lot of registry data, particularly from Korea, particularly the series of Shamir studies that support that. So, I think the data is reasonably conclusive. Whether that changes practice is another story. And as far as doing a lousy job, of course we do a lousy job, because these vessels are negatively modeled, underperfused. We have no idea what the size is, and most doctors want to get them on and off the table as quickly as possible.
But Gary, I want to say something, from a practical point when you're doing a imaging-guided PCI and STEMI, it's really hard because many of the things that we do in stable PCI, which is size the vessel and oppose the stent, is really difficult. So there's sympathetic drive. The arteries are always smaller, no matter how much nitro you give. So you're going to put in a smaller stent. And then you have thrombus holding the stent in. So when you come back and image them, some of the thrombus is now resolved because they've on DAP. So you almost invariably have malapposition. And then the artery's grown, A, because of flow-mediated dilation, but then also because it's attained its natural size, which is, I think, one of the real difficulties, because we're the same, we really haven't adopted in STEMI patients. I think what's really unclear is the ACS and STEMI patients, whether we can optimize to the same degree. But in ILUMIEN 4, when we did that, we didn't seem to achieve the benefit in that group. Part of that reason was probably what you guys showed before. It's not the lesion risk in that patient, it's the patient risk. It's the other vessels that have the TICFAs that come back with MIs and et cetera. So, a few comments on that, wondering what your thoughts were.
I'd like to recommend one thing is that before doing the intravascular imaging in the primary PCI in the S elevation, I'd like to recommend the practice of the imaging in the stable patient and the simple lesion and to get some experience, and then expand the more complex and the S elevation MI. If you ask just, it is a lot of time and there is a difficulty in the hemodynamically unstable and the S elevation, why do we use the imaging in this kind of the uncomfortable situation? Maybe if we have some experience and a lot of experience, and when we meet such kind of the S elevation MI, most of the experienced operator, why not give me the imaging?
Okay, so we have to go on because our time for the first half is up, and I'll turn it over to my co-chair, Myeong-Ki.
Okay, next topic is a very important publication in October, the OCT versus angiography for the true bifurcation. Dr. Holm from Denmark. Dr. Holm, please.
Thank you very much, and thanks for the kind invitation to this important meeting. My disclosures. So the background for the October trial was the very poor outcomes with treatment of bifurcation lesions in comparison to less complex lesions, both in terms of mortality, but also the other regular individual endpoints. So this was a particular concern whenever we needed to treat the side branch in our bifurcations. That means both a one-stent strategy with kissing balloon inflation, but also two-stent strategies. So With OCT, we had an idea that we would be able to optimize these results further, and already in 2016, it was very evident that a good fraction of cases of these techniques were suboptimal performed. So we randomized 1,201 patients with true bifurcation lesions to either OCT guiding protocol or angiographic guiding, and 16% of the cases in the angio arm were guided by IVUS. So we had the pleasure to work with 38 heart centers in Europe on this trial, and we provided extensive training throughout the trial in the OCT guided arm. The primary endpoint was positive in favor of OCT-guided PCI with a 30% risk reduction. Patient-oriented composite endpoint was a secondary endpoint, was not significant, but directionally in favor of OCT-guided PCI. So I had the pleasure to work with Ziad and Greg Stone on this work led by Greg Stone, published in Lancet 2 months ago, on the 22 randomized, including 22 randomized trials in almost 16,000 patients, the same meta-analysis that was shown before. So the estimate for the October trial was exactly the same as the totality of data in terms of target lesion failure. And when we look at the individual endpoints, October made a good contribution, a very strong contribution in terms of all-cause mortality, cardiac death, and ischemia-driven target lesion revascularization, although, of course, these were all insignificant because of the size of the October trial. So certainly showing the value of meta-analysis. Of course, the main point of the meta-analysis is the reduction in mortality that we see with intravascular imaging compared to angiographic guided PCI. If we look at the subgroup analysis for the October trial, none of them showed any interaction, but there was some signals of importance that we saw the same effect in left main and non-left main bifurcation lesions. And also maybe a bit surprising that we had a substantial effect with one-stent techniques and less effect with two-stent techniques, but probably a good explanation for that, because we asked the physicians to start out with one-stent techniques, and then when they felt comfortable with the protocol and so on, they should go on with two-stent techniques, and it was planned for a larger fraction of two-stent techniques in the trial in terms of power. But unfortunately, that coincided with a pandemic, so we asked physicians to do long, complex procedures, while everybody else told the physicians to do very short procedures at the time because they were in full protective gear and we wanted patients out of the lab as soon as possible. We could see that from the quality of the procedures, that certainly affected the outcomes. If we look at other metrics, we could see also, again, just an indication that side branch lesion length is important. So if you have long side branch lesions, you really have the benefit of optimization with intravascular imaging. So more details in the main publications. In conclusion, OCT-guided PCI was associated with lower incidence of the composite endpoint of 2-year MACE than angiographic-guided PCI in treatment of complex bifurcation lesions. The totality of data show that routine use of intravascular imaging in PCI reduces mortality substantially. The outcomes after OCT-guided bifurcation PCI appears to be in line with or better than the overall meta-analysis results. Implementing routine OCT guiding for PCI of complex bifurcation lesions may be justified, in particular as the effect was shown with 16% ad hoc IVUS in the control arm, and despite the COVID-19 pandemic affecting both the procedural quality and also the invasive follow-up. Thank you very much.
Excellent summary. And we will move on. Our next topic is ILUMIEN 4, OCT versus the angiography for the complex patient. Dr. Ali.
Thank you. So this is the first really large subgroup analysis of ILUMIEN 4. As you all know, ILUMIEN 4 was the largest ever randomized controlled trial comparing OCT guidance to angiography guidance that we presented at ESC. The main findings from that study was that OCT guidance could lead to a larger minimal stent area meeting its primary imaging endpoint, and also reduce procedural complications, including major dissections, major malapposition, tissue protrusion, and focal reference segment disease. Unfortunately, that did not translate into an improvement in target vessel failure at 2 years as the primary clinical endpoint. So what did we learn from a large global multicenter randomized controlled trial? Well, first of all, what we learned is that complex patients in particular did not seem to benefit at all from intravascular imaging in our study. You can see the hazard ratios are basically 1. And what that leaves us with is the concept that an intravascular imaging catheter can only fix what it can see. It cannot see whether you're diabetic or not. It can see whether you're heavily calcified or not. It can see whether or not you're a 2-stent bifurcation or not. So there's no benefit in complex patients. So perhaps we should focus on patients who have complex lesions. Now, one of the things that we found along with Niels is that we found a very stark difference in the endpoints during the COVID pandemic and prior to the COVID pandemic. Here you can see in patients that were randomized prior to the COVID pandemic with at least 1 year of follow-up, the hazard ratio of 0.70 was very similar to what we had powered the study for. However, during the COVID pandemic, we had completely lost this potential benefit. And why was that? The real reason for that was almost complete equipoise in target vessel revascularization. Perhaps this was a problem with access to care. Patients couldn't actually get to their doctor. Perhaps this was an apprehension to seek medical care with a deadly virus. All of those things dramatically reduced the ischemic revascularization rate from about 8% to 4%, as a result, limiting our ability to detect a difference. You'll notice that the hard endpoints, which includes cardiovascular mortality and target vessel myocardial infarction, show a trend, although statistically not significant, very similar to what we see in all of the other intravascular imaging studies for benefit. So in this study, what we designed is we focus specifically on patients with complex angiographic lesions, assessing for hard endpoints which are less subject to the bias of COVID, i.e. inability to access care. So these were patients who either had a heart attack, died of a cardiovascular cause, or had a stent thrombosis. This was a pre-specified analysis, and it looked specifically at complex angiographic lesions, longer multiple lesions, 2-stent bifurcations, CTOs, and in-stent restenosis. So 2,487 patients underwent randomization to ILUMIEN 4. We removed 514 patients who were enrolled due to isolated diabetes or acute coronary syndromes. 1,973 patients with complex angiographic lesions were enrolled, and there was 992 in the OCT-guided arm and 981 in the angio-guided PCI arm. All 1,973 had 2-year clinical follow-up. Our primary imaging endpoint was final post-PCI MSA assessed by OCT, and major clinical endpoints were serious adverse cardiovascular events, which is the composite of cardiac death, target vessel MI, or definite probable stent thrombosis. We also looked at target vessel failure for being scientifically hygienic. These were the baseline characteristics between the two groups. You can see that the only difference is a increased incidence of myocardial infarction in the angiography-guided PCI arm. In terms of qualifying characteristics, you'll see that the vast majority of inclusion of complex patients are long or multiple lesions. Please note that this is their qualifying characteristic. A long or multiple lesion patient could also have severe calcification, could also have a chronic total occlusion. You'll see in terms of baseline angiographic characteristics, these were also very similar with a longer lesion length in the OCT-guided arm. You'll see in terms of procedural characteristics, the total stent length and procedure duration, fluoroscopy duration, radiation dose, and contrast volume was higher in the OCT-guided arm. But advanced lesion preparation, the maximum stent diameter, the frequency of post-dilation, the number of post-dilation balloons used, and the maximum inflation pressure were also higher. So in terms of angiographic characteristics, actually post-PCI were all very similar. We didn't find any meaningful difference, and we will present you these results as a late breaker at EuroPCR on May 15th, 2024. We look forward to seeing you there. Thank you very much.
Okay, excellent summary. Please stay there. We have a 10 minutes discussion for the previous two presentation. Any comment or question is welcome from the panel or.
First of all, I apologize. I have to get to the main arena. But I think Niels should clarify that most of the IVUS was used in the left main patients. And that was one of the reasons why the outcomes in the left main patients were not quite as robust. In fact, a little hard to figure out exactly how many, but it may be like 40 to 50% of left main patients actually had IVUS in the angio arm.
Personally, I expect that your study should be the positive, but I really surprised that's negative. What is the lesion? The so complex lesion, large number of study population?
Yeah, I mean, anytime you have a large trial and you have a result like this, you go back and try to look for what the potential reasons were, which become hypothesis generating. I think there's absolutely no doubt in my mind that we were impacted by COVID, and the total number of ischemia-driven revascularization, which usually drives 70% of the power of the study, was dissipated because the number of events dropped in half from 8.1 to 4.1%. I think it makes sense that there was an apprehension for patients to come to the hospital and to undergo treatment. Niels found exactly the same thing with a much stronger benefit prior to COVID than during COVID. I think that's one of the reasons. And I do think that looking at complex patients was probably not the right thing to do. I also think that there are some fundamental differences between Renovate and ILUMIEN that highlight the potential benefit for IVUS. And that is, the greatest benefit in the Renovate study was in exclusions of ILUMIEN 4. Left main, chronic total occlusion, and osteolesions, where the hazard ratios are in the 0.3 range. Huge benefits. And all of those, unfortunately, were exclusions for OCT either because of technical reasons or because of regulatory reasons. So having said all that, I think what we need to do is go back to what Gary said and look at the totality of data. And looking at the totality of data, it tells us that intravascular imaging definitely helps guide PCI in complex patients.
You know, I look forward to this analysis. I think it's important because, I mean, you know, for somebody who does a lot of these ACS trials, they often have the simplest lesions. They're actually complex patients because they're ACS, but they're actual, if you look at the lesion, like if you look in complete one, the median syntax score was something like 8.
Yeah.
If you look at the lesion-specific score of the non-culprit lesion, because they're relatively younger patients. So although they are high-risk patients, the lesions that we're doing are relatively low risk in the grand realm of all the types of patients that we do. It's really the chronic patients with chronic calcified disease and bifurcations, and the really challenging cases are in the more chronic patients. But my question is that I found that the reduction in stent thrombosis was actually quite compelling in ILUMIEN 4. I mean, when you think about the things you want to avoid as an interventional cardiologist, that's one. And in our Cath lab, that's actually had quite an effect.
Yeah.
And a patient comes back, if we put a stent in somebody and they come back with stent thrombosis, okay, within 4 weeks, 8 weeks of having their stent put in, the first question people are going to ask is, was there imaging done when you put that stent in, and was that stent underexpanded? So it's become almost, you've really understated it because it's not the primary outcome, and I understand that, but I would really encourage you to do a full paper on stent thrombosis.
So that's planned with detailed analysis from Akiko, specifically on a patient level. I'll also just mention something with NSTEMI where we were hurt a little bit. So just remember to conduct a mega trial like this, as you all know, it takes years of planning. So the study was actually designed in 2016 when there was no high sensitivity troponin. Okay, so what the original NSTEMI inclusion criteria was, you had to have EKG changes for at least 30 minutes, and you had to have a troponin of 1 nanogram per deciliter. We picked that number based on Braunwald's data that shows you have a mortality benefit when you have a troponin of 1 nanogram per deciliter. In the middle of the study, we got high sensitivity troponin. Nobody got to 1 nanogram per deciliter. By that time, they were already in the cath lab. So we had to step away from what we tried to pick was really complex and actually genuinely high-risk ACS, and we ended up with a group of relatively low-risk ACS patients, like Shamir said, with really simple lesions.
Yeah, I have a question to Ziad. Approximately 10% of your patient population has CTO. How did you do OCT in CTO? Because normally we use IVUS instead of OCT?
Yeah, great question. So per protocol, you are only allowed to enroll a CTO, unlike any other lesion in ILUMIEN 4, where you had to cross the lesion and pre-dilate it, have the wire in the true lumen, and make sure that you could get adequate clearance. So you could randomize after you actually cross the lesion.
Hi everyone, I'm Manish from Abbott, so a bit of conflict here. Great talk, Ziad, and before that, Holmes as well. My question to you is, we do have all OCT experts or imaging experts in the room, and Evelyn very eloquently spoke about the training program of how to start imaging. So how does the result from ILUMIEN, October, Renovate, and other studies impact the program that she runs? I mean, in which direction she should be running the program, especially with regards to whether she should focus on complex lesions or on the simple lesions to start with?
Okay, so I'm going to answer that in two ways. One of the major findings that we got from the meta-analysis, so before this, the most recent meta-analysis, the number needed to treat that you needed to get a benefit from an imaging-guided PCI in all-comer patients was above 100. It was about 105 patients. You had to treat 105 patients to save one endpoint. That was the whole reason we focused on complex patients, because the NNT in complex patients was 1 in 34. But now, with all of the totality of data that everybody's put together in all comers, now the number needed to treat in all comers is 1 in 44. So actually, everybody benefits. It's just you need enough patients. Now, do you get an extra additional yield? Yeah, you get about a 30% additional yield in the complex patients because your imaging catheter can help you fix the problems that you otherwise wouldn't see.
Can I ask one question? Yeah. Good. Look at the three random trial, the Renovate, the October, and ILUMIEN 4. The one difference is that the ILUMIEN 4, the Kaplan-Meier curves did not diverge from the beginning. But the compared Renovate or October trial diverged at the first day. So what is the difference? How to explain the why? If you do the angio guidance, is it increase the peri-procedural MI?
I do not know your MI definition included the peri-procedural MI?
It did.
Oh, okay.
But we also did an analysis without peri-procedural MI.
Yeah, I believe the imaging, intravascular imaging can reduce peri-procedural event, so that's why the curve began to diverge from the immediately after the index procedure. And we analyzed the TVF without peri-procedural MI. Still, the difference was significant. So even though we excluded peri-procedural events, still the intravascular imaging benefit exists, and I believe peri-procedural events can be prevented by intravascular imaging.
Well, I think there are two effects pointing in opposite direction here, because when we do imaging guided PCI, we tend also to do more. We tend to do more optimization, and in some patients that will result in more enzyme leaks and maybe slightly higher risk of peri-procedural myocardial infarction. But that should be for the benefit of the patient, that get a better result and so on, affect the prognosis. The effect of the prognosis on peri-procedural myocardial infarction in itself is very, very limited. So, but in reality, what we saw was that just looking at procedure by procedure in procedural myocardial infarction, it was clear that the increased procedural control that you have with intravascular imaging, where you can predict much more, you have less problems, well, that certainly went down and benefited in terms of lower rates of peri-procedural myocardial infarction. So it is about prediction and make good plans and make careful optimization during the procedures, and imaging guided PCIs certainly have the advantages there.
During the PCI, Dr. Horon, please use the mic. I'd like to ask both of you, the imaging is important, and the next step is that achieving the stand optimization is the next step. But in your presentation, I did not, what is the optimization criteria and what is the difference of the clinical outcome patient with the stent optimization, without optimization? What is the difference in your data?
So I guess I can start there. So we had a Kiko running our core lab, so everybody optimized, otherwise you got slapped on the wrist. So actually our protocol, our adherence was exceptionally high, like almost 95% of patients. So very similar to Niels. Early on, we went out specifically and trained each site to MLD Max protocol. They learned MLD Max protocol, and then they'd submit their case and get real-time feedback within 24 hours. So everybody was doing a good job very early. And when we assessed the learning curve, we didn't actually see one because they were trained properly. So one thing when that came out, I said to myself, okay, whatever this study shows, I'm going to believe it, because it wasn't a problem for optimization. One thing that's very interesting that came out of the study is we optimized, but you probably saw still there was 15% of dissections that were just left. And there was major malapposition in 30%, it was left. And so why the operators knew per protocol to fix those things and didn't, we don't know why. And so that could be what, perhaps it's a training situation where they couldn't recognize it. Perhaps it was becoming so prohibitive to keep doing OCT runs that they decided to stop. So it's very much akin to like the PCSK9 inhibitors, which drop your LDL to almost nothing, but you still have 15% event rate. There's some background at which we can optimize. At some point, we can't optimize any further.
So is there any difference between a patient is the achieve stent optimization criteria or not? Is there any difference?
No, well, we didn't actually test it because there's almost all the patients were optimized. I don't know
What about your study?
Well, I think that analysis is probably obsolete because it's two very, very different populations. So those that have optimal results are much more healthy patients where you can get a good result. But it's much more important to see with this level of disease, did you do a good job as a physician? So, so to compare, optimal treatment based on, you follow all the steps per protocol to optimize. What did you get compared to if the physician did a poor job? Because you can have very easy procedures where you still do a poor job, but they will probably be in the arm where you have, optimal results. So I think it's important to focus on the physician, how they behave towards what they see on the imaging. And what we realized was that physicians react to roughly half of the findings across all the mandated steps. So if you see a wire position that is wrong, well, it's identified in roughly half of the cases in the Cath lab and corrected. If you see suboptimal suboptimal plaque preparation, it's identified in roughly half of the cases. So it's consistently roughly half. So we need to do much more training and also much more automated assessment with new AI-based systems. That will certainly also help. So, but there's no doubt, if we look at the cases in the OCT-guided arm that was not imaged by OCT, they by far had the worst outcome. The number one predictor of events was segments that were not imaged. So if you don't image, well, you don't see it, and you cannot correct it.
Okay. Any other comment or question? I think it's last one.
Yes. Regarding the benefit of intravascular imaging in acute coronary syndrome, we have to concern several things. Acute coronary syndrome has various spectrum, simple lesion and complex lesion, and high lipid core burden, thrombus, or nothing. So first, the clinical variability, and second, we don't have exactly how to prevent procedure-related myocardial infarction and how to optimization using intravascular imaging. That might be problems we have to overcome to increase the benefit of intravascular imaging in acute coronary syndrome.
Okay, it's time to close. I'd like to say thanks and the four speaker and every panelist. Thank you for the all audience to attending this session. Thank you.